So the objectives today, we're going to talk about the idea of interstitial lung disease being a serious illness. Okay? We're going to talk about the features of palliative care and hospice. We're going to recognize when it's time, okay, and discuss when it may be appropriate for you, and how to locate those resources. And I don't have any disclosures. My apologies, the slide isn't there. So this is the interstitial lung disease family tree, okay? This comes from the American College of Chest Physicians, and what I love about this image is that it shows all the different ways that ILD presents. Okay, it can be due to medications, it can be connective tissue disease, it can be idiopathic, meaning we don't know why, and it can be some of the rare genetic diseases. There are over 200 interstitial lung diseases, right? But ultimately, they tend to present the same way, and we have a responsibility to care for those symptoms. Pulmonary fibrosis is a subset of ILD, right? And we're talking about scarring of the lungs. So what are the most common symptoms patients experience? Shortness of breath, cough, fatigue, weakness, right? All things related to the delivery of the body needs oxygen to do its job. But there are additional symptoms that come along as well. It can be weight loss, loss of appetite, depression, anxiety, and the list goes on. We aggravate these symptoms with a lot of the medications and treatments that we use, right? I'm sure anybody who's been on antifibrotic medication knows what the nausea or the diarrhea that comes along with it. The challenge with pulmonary fibrosis is that as the disease progresses, the number of symptoms that develop tend to increase, but also the intensity of those symptoms. And pulmonary fibrosis is considered a serious illness, all right? And that's newer language. It's something that we're trying to adopt because it's different than when you were diagnosed, you're probably told that pulmonary fibrosis is a chronic disease, which it is. It's lifelong. It won't go away. But the idea of serious illness is a new concept, and the idea is that it carries a high risk of mortality, and it negatively impacts your daily function or quality of life, and can be stressful on the caregivers. Now, that comes from the Serious Illness Messaging Initiative, and why that's important is that that has to shift how we think about caring for you, caring with you. So when we shift that care model, we really need to focus on you as a patient and as a whole patient. We need to adopt the ideas of shared decision-making. Long gone are the days of a provider coming in and telling you the care plan, and that being that. You're involved in this process. You have to be part of the decision. It needs to be patient-centered. Whatever care plan we come up with together, it has to be centered around you. Not what's best for our program, not what's best for our doctors, not for our nurses, for you. It has to support autonomy. The idea of autonomy is that you are able to make decisions based on full information in front of you, and that we support that. So we have a responsibility to get you those information and that resource so that you can decide how you want your care to be. And we need to be active listeners. That's much more the important part of this, right? This isn't going in, reporting about pulmonary symptoms, and that being that. We have to listen, we have to ask questions, we have to understand what your goals are. So when we approach pulmonary fibrosis as a serious illness, we bring up the idea of palliation, okay? And by definition, palliation is a relief of symptoms, okay? Relief of treating those symptoms. And it's typically delivered in 3 levels: primary palliative, specialty palliative, and then hospice. So primary palliative care is delivered by any provider that you see. This can be done by a primary care physician, or provider. It can be done with your pulmonologist or whoever you're seeing in your pulmonary team. The idea is that we assess you both physically and psychologically. We might use some screening tools. We're going to do physical assessment. We're going to ask questions. And we treat the basic symptoms and your disease at the same time. Okay? These things are delivered concurrently. A lot of times pulmonologists don't recognize that they're providing palliative care. Okay? Pulmonary rehab is a form of palliative care. It allows you to exercise, make your breathing more effective, improve your quality of life, hopefully, increase your ability to participate in activities of daily living. That's palliation. That's treating a symptom. Oxygen is relief as well as some medications. Oftentimes those medications are going to be for cough, nausea, acid reflux, the kind of symptoms that come along oftentimes with disease treatment. Okay. The challenge for primary providers, though, is that their expertise doesn't necessarily lie in treating all the symptoms that may come, and their comfort is pretty limited at times, too. It's pretty well established that, for example, as cough progresses, right, we might prescribe steroids, okay, we can give you medication treatment, we can give a cough suppressant, right, but there might be other medications that we can use that a provider may not feel comfortable with. And that's when we need to think about specialty palliative care. So specialty palliative care is an added layer of support. That's what it is. It's a specialty in the same way that cardiology, you would go to a cardiologist or a rheumatologist we would refer you to. Palliative is delivered the same way. It's been shown to improve quality of life. It helps with both caregiver and patient distress. It can improve symptoms, and it increases the frequency of advanced care planning, which is a really important part, and we're going to hear more about that later, right? But the idea of making sure that we know what your plans are, your desires are, as your disease progresses, if you can't make decisions for yourself. It's a focus on quality of life through symptom control and clarifying what your goals are. Full disclosure, and the literature supports this, and I think you can ask any pulmonologist, we do a really good job of focusing on your lung disease. We don't do a great job of assessing you holistically. You are more than your lungs. You always have been, right? You are someone's child. You might be someone's spouse. You may be someone's parent. You're a member of your community, and we have to treat you that way. Palliative care can step into that space and assess you in all of those factors and treat you accordingly. Palliative care is appropriate at the point of diagnosis of a serious illness. This means that from the time you are diagnosed, you can receive palliative care if it's something you want. It's a team of specialists, multidisciplinary. So you may have a provider, so a nurse practitioner, a physician's assistant, but it also involves social work, psychology, pharmacy. It's a multidisciplinary team that will help to support you and help you access the resources you need. They assess you in a variety of domains, okay? Physical, psychological. They address spiritual concerns, legal concerns, cultural concerns, and end of life. Now that might include advance directives or assigning a healthcare power of attorney. And those are really important. The reality is, if anybody's been to their provider's office, it's a 15-minute visit, 30-minute visit, right? And if you're fortunate to be at a center that has an expansive team that can meet all these needs, it's great. But most providers don't have those kinds of resources. Hospitals aren't necessarily set up that way. And so palliative care can step in and help support us, support you in your care. And we collaborate with them. We work together. They can order medications, equipment, and therapies as appropriate, again, in collaboration with your primary provider, and it's delivered alongside active disease treatment. It can be administered in an inpatient setting, but the best part is a lot of it can be outpatient, and outpatient is as you want it. It can be in an outpatient clinic, where you go in for an appointment just like you would for any other visit. But also at times, depending on where you live, it can be delivered in your home. They will come to you, whether you live in a home by your freestanding home, if you're in a skilled nursing facility, in an assisted living, they come to you. They can, and not only, and I might not have shared this before, they treat you, when I say you, I mean patient and caregivers, okay? You are a unit. It's one of the best features of it is that when we talk about palliative care and when we bring it up to patients in clinic, the number of caregivers that say, thank you for recognizing me. Thank you for recognizing what I see and what I feel and how I can impact this care plan. Most palliative care is covered by insurance, though there may be a copay. When palliative care isn't enough, when symptoms progress, we have to discuss hospice care. I will dispel a very important a rumor, a common one, a misunderstanding. Hospice care doesn't hasten or speed up the dying process, nor does it postpone death. The focus is on comfort and symptom relief. That's why hospice comes in. It's a transition away from active disease management when we're not making progress and the symptom burden is too high. It's ordered when we think that you have, as a patient, 6 months of life left or less. And that's a heavy thought, but it's a really important one because the quality of your life is more than the lungs that we've been treating, right? And we need to attend to that. It's provided by that same kind of multidisciplinary team with a few added members. Oftentimes, patients who are enrolled in palliative care can transition straight to hospice care through that same group that's delivering the palliative care. A hospice team is going to come in and assess and treat distressing symptoms. Pain tends to be the most common one, but it also thinks about shortness of breath, cough, nausea, vomiting. It can include medications, relaxation, massage, any number of different therapies that bring you comfort. They'll supply the needed medications and equipment, particularly if you're going to be receiving care in your home. Hospice will educate and support caregivers through the end-of-life process. It's scary. And I say that as having family members who've received hospice before. As a healthcare provider, I needed information. I needed guidance too. And they were wonderfully helpful. They also provide bereavement services after a patient's passing. Hospice can be delivered, again, in the same places. This can be done as an inpatient in a hospital. It can be delivered in your home. It can be in a nursing home or an assisted living. And it can escalate over time. So typically, the hospice will come out and evaluate you and see kind of where you are. They'll see you on an as-needed basis, whether it's weekly or every other week. And then as your needs progress, they'll come and see you more often ending with continuous care around the clock coverage to make sure that you're supported. Hospice is covered by most insurance, and it is covered by Medicare. So the question is, what's the right time? Right? And the answer is, you tell us. You decide. It's not our decision. I am not an expert in what you define as quality of life and what's important to you. No provider is. So we need to understand from you when it's important, when you want that added layer of support. It's appropriate, palliative care is as appropriate as early as a time of diagnosis, but there's never a too early time. But there are times we should start talking about it more often, thinking about it. As symptoms start to impact your quality of life, that might be appropriate to bring palliative on board. If you're experiencing more frequent hospitalizations or acute clinic visits and your needs increase, that may be appropriate as well. If your symptoms are getting worse despite the treatments that we're providing, we may need to bring in someone else to help us do our job better. If you're experiencing distress, both as a patient or a caregiver, and if you have limited support, not everybody has caregivers who are available to help, and palliative care and hospice, for that matter, can really offer that extra level. And ultimately, when you and your caregiver say it's time, that's when it's time. Now, there are some obstacles or barriers to palliative care that we have to recognize, and all of them very legitimate. Patients are scared. Patients are anxious. And there are a lot of misconceptions. Patients will say, they told me palliative care, it must be the end. No, it's not. It's an added layer of support. For families and caregivers, they have the same misconceptions. They also at times worry about upsetting the patient. What if you're asking for a palliative care referral, is it going to be more distressing for the patient? That's of a concern, and it doesn't have to be. Caregivers may also be anxious or fearful of a patient's impending death. Providers, we are a barrier. We always have been, but we're working on it. And it's been a lot of progress. There's, again, Dr. Lindell has been working for decades now, right? Trying to improve the space, and we are making progress. But sometimes we have a difficulty recognizing what symptoms you're experiencing that we're not adequately addressing. We don't always ask the questions. We don't always have the time to do so. Some providers aren't aware how available palliative care is, particularly in the outpatient setting. The literature supports this, but in my work, that was the number one thing. It's not really accessible in the outpatient setting. That's incorrect. Providers don't always know when to refer. They don't know when the right time is. And they also worry about patients thinking they're giving up. And then from a resource perspective, there are some limitations specifically for palliative care. This is the case typically for patients in rural settings, much more rural settings, where they may not have adequate services out there. It is improving and has been improving over the last several years, and palliative care is an expanding space. It's a service that is really advancing, and so I think we're going to make progress there, but at this point it's still limited. So how do you access it? Your provider may bring it up in a clinic visit. They may tell you, I think it's time. I think it's time that we talk and bring in an added layer of support. Second, though, be your best advocate. Ask questions. Everybody here who's at the conference is incredibly invested in the pulmonary fibrosis community. We are trying our best. We keep working, but we have our limitations. And so we need you to be your best advocate too. Ask your provider where you are in your disease process and where they think your trajectory is. Tell them what your quality of life means to you, what your goals of care are. We don't always ask, but you can tell us. You can ask for a referral. You're well entitled to it, and it's something we can and should support. And it's important to recognize that referral for palliative care or for hospice does not mean that you have to enroll. It gives you choice, though. It gives you the options so that you can decide what you want to do with it. And if you do decide to pursue it, you can always ask your pulmonologist if they have a preferred palliative care or hospice provider. There's some great resources available for patients and caregivers. My favorite is the Center to Advance Palliative Care. GetPalliativeCare.org is a wonderful website. It's the patient-facing side of the organization, and it answers frequently asked questions. It actually has a little survey that you fill out to say, is this maybe the right time to consider palliative care? And it also has a provider directory. You put in your zip code, and it can identify home-based palliative care, outpatient clinics, and inpatient services available near where you are. Pulmonary Fibrosis Foundation is a wonderful advocate for palliative care and hospice as well. There's a wonderful video featuring Dr. Lindell on there under the symptom management. And there's also a palliative care position statement that explains more about palliative care for patients. And also, this is the one time a healthcare provider is going to tell you to go onto Google and take a look, okay? And the reason I say that is that sometimes patients are able to find palliative care services closer to them that may not be in that directory simply by Googling. Finally, ask family, ask friends, ask neighbors if they have experience with palliative care or hospice where it's been a good experience, as that might be a good source as well. Thank you.
Hi, everyone. It's such a pleasure to be here and speak with you all today. I will share with you some stories of my patients, patients that have gone through various phases of palliative care and some that have decided ultimately to enroll in hospice. I have no relevant disclosures or conflicts of interest. So I want to start by introducing you to Rick. Rick is a very proud school bus driver, now retired. He is a family man. He is happily married, living with his wife, has 2 daughters. One is in college, and one is actually in New York City, performing in theater and getting married next year. He was diagnosed with pulmonary fibrosis in 2016, and around that time, developed a really intractable cough, became increasingly socially isolated, and then when COVID hit in 2020, he unfortunately noticed that many people were scared to be around him because of his cough. They didn't understand that he didn't have COVID. And so he unfortunately became more isolated to the point where he wasn't really leaving his home. And so throughout this talk, you're going to, hopefully, if the technology works, hear from my patients. So this is, when I initially met Rick and kind of broached the topic of palliative care, his thoughts. Okay, so we're having some technological challenges, which is okay. I wish you could actually hear it from these patients' voices because it's far more powerful than mine, but I will paraphrase what you would otherwise hear them saying. So when I broached the topic of palliative care with Rick, you know, his thoughts were that he had heard of and kind of had some experience with palliative care through people that he knew with underlying malignancies, but he didn't really understand that there was a role in patients who have pulmonary fibrosis. And so, you know, I kind of then moved forward and said, well, what if we try palliative care? What if we just talk to you a little bit more about symptom management and what we can do to try to get you feeling better and feeling a little bit more supported? And so, you know, he was very open to the concept, but just remained a little bit hesitant because he didn't in any way want, you know, him deciding to receive palliative care to then in some way hinder his life expectancy or kind of be forced in any way to change his overall goals, which were to keep going and just try to feel better. And so, you know, this is him just kind of sharing those overall thoughts that I had paraphrased. And so if we move forward, so I was his palliative care physician. And so what did we do to get Rick feeling better? So he came to me at extremely low doses of gabapentin and told me it didn't work and just stop them. So we actually got him therapeutic on gabapentin. We used appropriate dosing and his cough almost went away. You know, looking through his chest imaging, I think that he had a little bit of mucus that was getting stuck in his airway. And so we got him a vest to kind of help him to expectorate or cough up that mucus. He did end up seeing a therapist to talk through, you know, some of his concerns and some of his thoughts about his disease and about the cough. We actually got him into physical therapy. And then, you know, we talked a lot about the importance of socialization and making sure that he really felt a part of his various communities. And so, unfortunately, you won't be able to see, this is Rick's wife, and she's really sharing kind of when, you know, we started working together in a palliative care capacity, how Rick really started re-engaging in the community in a way that he hadn't before. You know, he became much more physically active as a result. And, you know, his wife just kind of shares how beautiful it was for her to watch this transition in her husband. And he had no change in his lung function during this time. He just felt a lot better and was overall happier, felt supported. So overall, how did Rick's life change with palliative care? So he went from kind of sitting in one chair for most of his days, other than getting up to use the restroom, to being able to ambulate as much as he wanted to. He and his wife during the summer started going to the pool and they had a lot of fun there. He was able to get back on his motorcycle, which was really important to him. And then, you know, I think most importantly, he was able to reconnect with family and friends that he had really lost touch with because of the cough. And I continue to see him monthly in the breathlessness clinic, which is once again our palliative care clinic for patients with pulmonary fibrosis. So next, I want to introduce you to Joyce. So she has been very happily married for 61 years. She's got 3 beautiful daughters and so many grandchildren, I couldn't even count them all. She was diagnosed with pulmonary fibrosis in July of 2022. She was actually living in North Carolina at the time, had several hospital admissions, was started on oxygen, and her daughter mother, who lives in Baltimore, actually drove down to North Carolina, picked her up from the hospital with oxygen, drove her up to Baltimore, and brought her to our emergency room. We admitted her, and she ended up subsequently moving to Baltimore, and she's been my patient ever since. Unfortunately, shortly after she did move to Baltimore, she became very sick. She had a 5-week-long hospitalization. The majority of the time she was so sick, she was actually in the intensive care unit. And so what I was hoping to show you is a video of Joyce kind of talking about what she remembers from being in the ICU, how scared she was, and then subsequently looking at pictures of her time in the intensive care unit, and really reflecting upon that experience and deciding, that's not something that she wants to go through again. So here are pictures of Joyce. I actually was her ICU doctor during the majority of this time. I was extremely worried about Joyce, and I honestly wasn't sure she was going to make it. And honestly, probably by a miracle and a lot of different medications, she actually completely came off oxygen. So I, in addition to being her primary pulmonologist, I'm also her palliative care doctor. And so, we've talked a lot about how her time in the intensive care unit has shaped the way that she looks at medical care in general, and how that's kind of changed her preferences about overall care. And so ultimately, at the end of her 5-week-long hospitalization, she completed an advance directive, which we're soon to learn more about, kind of clearly stating what her preferences for her care would be. And so here is an interview that I do with her where I kind of ask her to share with you all, because she knew she was speaking to you, or thought she would be. And what she says is, what's most important to me is, to make sure that my symptoms are being managed, that my family is by my side, and that I'm not suffering at the end of my life. Oh, you do? Okay. If I click it, will it play? It's playing. I don't think it's working. It's okay. We'll just move forward. And so once again, I kind of end our interview and what she was hoping to share with you all by asking her, what's most important. And she really shared, being with my family and making sure that I feel comfortable are the two most important things to me, and that's really overall shaped kind of her decisions about care preferences. All right, so here's Joyce now. So Joyce is actually totally off oxygen. Here she is swimming with her granddaughter. This was actually the holidays about a year ago, which was a year after our 5-week-long hospitalization. And here she is with 2 of her youngest grandchildren on the right. So the next person I'd like you to meet is Joanne. Joanne is one of the kindest souls I have ever met. She was a teacher to her very core. She was a very devoted mother to her 2 children, as well as 2 grandchildren. She, about 15 years prior to when I started working with Joanne, had a very traumatic loss of her husband. And he ended up at the very, very end of life, enrolled in hospice care, and it was actually their daughter who cared for him at that point. Go back. Okay, sorry, we skipped ahead a little bit. So she was actually incidentally diagnosed with pulmonary fibrosis in July of 2022 when she was actually getting an MRI of her spine to plan for a spine surgery. So Joanne needed a lot of oxygen, and she was pretty sick when I first met her. So we actually did an expedited workup for lung transplant, actually got her listed for transplant. And unfortunately, before we were actually able to get her transplanted, she started having a lot of issues with pain in her back. She never was able to get that surgery that she was being worked up to get. And then she kind of became increasingly frail. She wasn't eating as much. She was in and out of the hospital many times, in and out of different rehab centers. And, I remember doing FaceTimes or Zooms with her kind of in different hospital settings, in different rehab settings. And, I kind of watched as she just really was suffering very deeply. And I'll never forget, in rehab, she would push herself to walk so hard that she would actually vomit. She was that motivated of a person. Her body just wasn't there. And so working with her 2 children, we all had a lot of really tough conversations. And her daughter, who is on the left in this screen, Natalie, honestly was the real hero in this situation. She fought so hard for her mother, and ultimately, after all of our conversations, wanted her mom to find peace. And I think this was particularly important because Natalie had so much trauma from the death of her father, and yet she was such a strong individual that she worked past that, and she really helped her mom to kind of come to the decision that unfortunately, a lung transplant was not an option for us anymore, but we could go home and we could receive hospice support. So Joanne goes home. She meets her new granddaughter for the first time. And she gets to be in bed with her dog. She gets to hold her grandbaby for hours during the day. And while this may not have been how we had initially seen things for Joanne, life intervened and we just kind of rolled with the punches and we figured out how to make the best out of the situation. So I want to thank you for listening. I'm so sorry we couldn't have the audio, so you couldn't hear patients speaking themselves. But thank you all, and I will echo what Kathy said. None of what we say is ever meant to scare you. It is really just meant to try to empower you to know that there's extra supports and extra modalities of care that you're absolutely entitled to if and when you decide that's the right decision for you.
Good afternoon. Now I feel like I'm shouting. We have a very short amount of time to talk about a heavy and meaty topic. And so with that said, I want to point out that you'll find a packet of material, and if you don't have one in front of you, one of our staff members will deliver it to you merely by raising your hand. I felt it important that while I'll scratch the surface of this topic, there's so much more that you can glean. And so this packet of materials covers a lot of what I'll be talking about and more. It'll also provide you some worksheets as well as some helpful tips. So I hope you find it helpful. So I'm going to get started with an exercise. By a show of hands, who here has lost a grandparent? And you can keep those hands up. It won't be long, don't worry. And who's lost a parent? A sibling? We're going to start putting our feet up now, aren't we? And a spouse. And we could go on, but virtually everyone, if not all, in this room has lost someone. And so we know how difficult experiencing loss is, particularly of a loved one. It's a complicated situation, particularly if you're then also asked to put their financial and estate plans in order and to collect information. Sometimes it's like you're taking an advanced class history test and you don't have the book. So what I'm going to talk about is trying to put things together in advance. You'll hear more. Okay, great. So as we all know, denial doesn't change the outcome. So what we want to talk about now are things that we can do to improve the outcome, to actually have a good outcome. You can go to the next slide. I'm so glad you're doing it for me now. Thank you. So we're going to be talking about a few ways to do that, to have a good outcome. A financial assessment will be one that we'll talk about, whether or not to involve your family. Housing and care alternatives, some of those more immediate topics of concern and question. And then the record retention file, the red file. Trust me, it can be green, yellow, purple, but more often than not, you hear the red file. That's okay, we're going there next anyway. So one of the first questions that people ask all the time is, why is it necessary? I know what I've got. Who else needs to know? I've got it under cover. But unfortunately, it really does make a difference, and we'll talk more and the reasons for that. And is it necessary to involve my family or include my family? I'm going to go focused on that one first. Yep, back one. Thank you. Oh, good. Oh, it keeps bouncing. All right, we're there. So family members carry more of the brunt than we realize, and they take on an enormous amount of responsibility, particularly when you're no longer able to speak on your own behalf, or worse yet, that you've passed. And it's not just about the person passing, it is about how you leave things for your loved ones, answering a lot of the questions that they're going to have for security purposes. There's a lot of vulnerability when we lose our partner or a loved one. And then there's the financial implications. So on the financial implications, we'll talk about all of these, but we're going to jump into the next slide. All right, financial assets. So I want to stop and pause for a second because I learned a lot of valuable lessons from my great-grandmother. She was about 4'8". She was definitely feisty. And she'd put one hand on her hip and she'd put the finger up and she'd tell me, knowledge is power. And you know, she was right. She was definitely feisty, and you can tell she was a product of the Depression. But what mattered was she was giving me really good guidance. I think that's why I've been in financial planning for 30 years. So that said, we take a look at, by taking a look at our financial resources, we're really taking time to recognize what the decisions not only that you have to make right now, but that your loved ones are going to need to make as well. This is especially important if you're the primary income earner, you're the primary record keeper of your financials and other affairs, and you've been paying the bills all along. And so you can imagine, upon your passing, your spouse is going to have a lot of questions. Some of these questions will be, do I have enough money to live on? Will I still be able to stay in my home, or am I going to have to look for myself and my family to alternative living? Will they be able to continue to pay the bills? And how will they pay the bills? And are they going to be safe and secure? These are all things that are going through the surviving spouse's mind. And by doing an assessment, you're gathering this information to be able to reduce the stress, if not eliminate it, and help these loved ones prepare for what they need to pick up on and what to do going forward. So this slide, it talks about the financial assessment is simply taking what are your sources of income, what are they now, and what will they be after you pass? Will they continue for your loved one and or your family members? Or will they change? And if so, how will that impact the family? The second part is the Social Security and pensions and government benefits. Some of those will cease. So we need to make sure that what you were expecting would carry on for your spouse or your children or otherwise, that continues to or not, and understanding what you can do to look at alternative assets, which leads then to bank and investment accounts. Now, importantly, we're going to look at the bottom right: debts, mortgages, credit cards, vehicles, installment loans. Ideally, you have enough income sources to continue to satisfy those. But oftentimes, we've taken advantage of opportunities, particularly to gain insurance, life insurance. Is that going to be of value to be able to either satisfy debt or provide additional assets, thereby supporting income needs for your loved ones? Hopefully, you've had long-term care or disability insurance to hopefully carry a lot of the expenses that you're enduring present day. Those will go away, basically, upon your demise, but at least you've protected the assets you have so that your loved one has those to rely on going forward. Next slide is fine, thank you. So then, with this information that you've collected, you're able to better help yourself make decisions as well as your survivors. Where will you live? Do you want to continue to live in your home? Will you need to look at renovations to be able to do so? And how will you tap into sources of income, if not potentially a home equity line, to be able to renovate the property so that it's still the right place for you to be? You may consider other alternatives for you and your spouse, whether it be a nursing home, assisted, or independent living. Those come with expense. And so now you have those financial assets in the summary, so you can start to make informed decisions about their options, but what can you afford to do? And again, going back to your insurance, whether or not you have that should continue to help you during that period of time, and thereby continuing to protect the asset or the nest egg for future need. All of these things impact not just you, but your family. And so taking the time to review this and to discuss it with your family, they're going to understand the nature of the decisions being made, they'll participate in it, and you'll have a far better outcome. So the question comes next, where do you store all of this information? The infamous red file. The red file is a file first, I guess I should answer the questions. What on earth is a red file? It can be a simple file folder that you are leaving instructions and guidance for your loved ones to know where first to look. This is a very daunting experience. They've just lost their loved one. The last thing that they want to do is worry about finding information that they have no clue where to look for it. So if you have a simple summary of a lot of the details about what we've just talked about, it'll come in very, very handy. I can't tell you how often I found in my career in investments, trust, and planning, the number of individuals that were suddenly widowed. And all too often they were the females, and they were not the ones that were paying the bills, they were not the ones that kept the records, and they weren't the primary earner of the income. And so that vulnerability really gets exponential during this time. On more than one occasion, I would sit on the bedroom floor of a client's home, pulling at boxes, getting things from different rooms, and literally going through to try and put the puzzle pieces together. It was a lot of time, and time is money, but it's also just that duress on an individual that's really trying to deal with her emotions or his emotions and not having to worry about this. So that red file becomes very, very important. So some of the things that you'd put in a red file: contact information for your advisors, whether it be an attorney, a CPA, your financial advisor, locations of documents. So while you've referenced it in your red file, now you're going to talk about, is it in the safe to deposit box? Is it in, and some records are meant to be in a safe to deposit box and some are not. There's an article in your pamphlet, and it's really important because you need readily available access to some of these documents. Other things to consider putting in there: wills, trust, social security cards, birth certificates, marriage certificates, divorce decrees. Again, you can reference that it's in the safe, the home safe or otherwise, but it's good to point out where exactly it is. And then the detailed list of your financial assets, what we talked about as far as your income sources, your asset base, your insurance policies, beneficiary designations. And most important, we're in a digital world. Passwords matter. And I can't tell you how many times I've heard that one password that was missing, or worse yet, the cell phone code. Because if you don't have that, you can't get access to so many of these records. List of people you want notified upon your demise, and then funeral preferences and final wishes. Organizing your documents is a gift to your loved ones. It shows that you care about their well-being. So by taking this time, and you can do it together with them, everybody, it takes a village, right? So being able to organize this is just a huge gift. I thank you for your time.
This is a tough discussion to have, and today I'd like to talk about the legal considerations as you sort of navigate the advanced care planning journey. And what is advanced care planning? It is a comprehensive care plan that allows you to be able to tell your loved ones, your healthcare providers, those wishes, wants in your journey through pulmonary fibrosis. And so let me go to the next slide. I kind of wanted to bring this visual because I think for me what it evokes is how inextricably connected a patient is with their healthcare providers and their caregivers. And central to that, and a prevailing theme that you've heard today, is that as a patient, you really are your own best advocate in ensuring your journey through your advanced care planning is exactly as you want those final years to play out. And as I've discussed with support group members, I consider this as a mutual act of love. And here in this discussion, I'd like to focus on the relationship between patients and your caregivers, because as a patient, it is an act of love when you are finding the strength and the time to reflect and think about the things that are important to you and the wishes you have, and to be able to effectively communicate that to your loved ones. And as a caregiver, to be able to receive, understand, and accept what those wishes are, even if you don't agree with them. And having those discussions as a constant, not a static conversation, but as something that's continuing throughout, is integral to this process. So some legal considerations you might be having or thinking about today, and these are questions that support group members have asked me through the course of our clinic, which is, one has been, I already told my daughter what I want. To me, that assumes that this process is static, right? That there's just one point in time that you're thinking about your wants and needs. But this is really a process and a journey where your thoughts and your needs might change over time. And so by putting it down on paper, you're able to evolve what that might be, and it also effectively communicates to those around you, and including your healthcare providers, about what your wishes are and how they may change over time. I've also heard, well, why do I need a will? I don't own anything. Interestingly, a will, although it really is for, the distribution of your assets, and if you have minor children, who's going to care for them afterwards, it also serves as a legal instrument to be able to appoint an executor of your estate. There are a lot of things that happen after someone dies, and to remove that complexity of forcing your loved ones who are grieving and in an otherwise vulnerable state to potentially have to go to probate court and litigate, it creates unnecessary expense, time, energy, and through that process, I would tell you or challenge you to think about removing that through an already difficult time. And third, This is probably one of the most common ones. I was just diagnosed. Why do I need to be thinking about this now? And as you've heard, another prevailing theme today is that pulmonary fibrosis is a serious, chronic, irreversible, and highly likely progressing disease. And so, although I would tell any person of any age, of any health status, that this is a discussion they should be having with their loved ones, I would tell you that needs to happen sooner rather than later, again, to avoid the confusion and unnecessary and unintended consequences that could result if you don't. So what are some of the legal documents that come into play? I just spoke about a will. There are trusts for those of you who have maybe more complex asset distributions. But really, I'd like to focus on living wills and advance directives. These are important because these are really the questions to delve into, as to the ones that ultimately inform how you want your care to follow through. So, for example, your do not resuscitate or intubation orders. There are various questions related to these medical decisions, like, do I want to be on artificial life support, mechanical ventilation, feeding tubes? Really difficult things to think through, but again, I would submit to you that it is better that your loved ones know what your wishes are, rather than for them to find themselves in a really difficult position in the hospital, having to make those decisions under stress and grief and worry, and potentially guilt that maybe they got it wrong and maybe not exactly what you wished for yourself. And certainly, as you've heard today, the decisions around palliative care and hospice care, and really thinking through what those wishes are. And then powers of attorney are also really important. Powers of attorney are those documents, again, legal in nature, that allow you to appoint someone, not necessarily a loved one, but someone you trust, to make either healthcare decisions if you're unable to do so, as well as financial decisions, because those two can really, as Lori had covered, there are some significant financial decisions that need to be made along the way. And so if you want to click just a couple more times, what the biggest reminder, though, and the biggest takeaway with regard to this slide is that depending on the state that you live in, the laws vary. And these are legal documents. And so, if you have the resources, I would highly recommend that you hire a licensed attorney to advise you on your particular set of circumstances and provide you the legal guidance that you need to get these documents in place. And then if you need to revise it along the way, that you have someone who's qualified to advise you to do so. So I am a lover of mnemonics, things that allow me to associate words to remember later on. A lot of these topics have been discussed today, but if I could ask you to take something away today, not only to be empowered with the information and knowledge that hopefully allows you to have attained more education and awareness, but also to think through the word trust, which again, going back to my initial slide on the relationships that we have here in the acts of love, that you as a patient genuinely sit down and are introspective to think about your needs and wants, that you record them properly with the help of an attorney. And through that process, like I said, it is not a static process, that you're having ongoing conversations with your caregivers, your loved ones, your healthcare professionals, your healthcare professionals are going to be in a great position to offer you guidance and advice, as we've heard today, about what your options could be for end-of-life planning. Then you've got to clearly communicate to help your loved ones understand what you want. You've got to sit down and have those tough conversations about where your mind is at and what you need from them from a support standpoint. storing your documents safely and letting your loved ones know where they are, providing them copies, providing a copy to your healthcare provider once you have some certainty as to what those needs and wants are is also crucial to the process. And finally, being timely. There have been several studies about people who, and their thoughts about end-of-life planning, and as many as 90% of folks polled have said that this is a really important conversation to have, but it's like close to 30% actually do. And so being timely and following through with these discussions are really crucial as well, to ensuring that you have everything in place as you think this through. And again, this could be relevant to anyone of any age, of any health status, but I really do urge you to think about it seriously as you go through your advanced care journey. And so that's it for me, and I thank you for your time, and hopefully you're empowered to have the conversations.